This is Dr. Howard Strassler with a Hints from Howard on adhesives, and today I'll be talking about the evolution of adhesive restorative dentistry, where we came from, where we are now, and where the future may hold. It all started at the Eastman Dental Center in 1955 in Rochester, New York, when Dr. Michael Bonacore investigated the use of the phosphoric acid liquid in zinc phosphate cement, and he looked at it as far as could it have the potential to roughen enamel surfaces to get resins to adhere to those surfaces. His research led to two really seminal articles in bonding in the Journal of Dental Research in 1955 and in 1956, the bonding to enamel and the bonding to dentin. And then bringing it full circle by talking about sealing of pits and fissures with an adhesive resin. In the Journal of the American Dental Association, 1967, the first research paper on use of adhesion and using it for prevention. And Michael Bonacore asked the question, what if? What if we didn't have to be as destructive to tooth structure when placing our restorations? That we can take a class 4, worn, fractured situation of these two anterior teeth, two central incisors, and using a mild organic phosphoric acid, etch those teeth, place adhesives, and place a composite to place what I call adhesive invisible restorations. Or what about the replacement of these dark amalgam restorations with something more tooth-colored that'll have the longevity and predictability of the amalgam? And in fact, using adhesion, we can place composite resins that will be equivalent to amalgam in their clinical success. And let's face it, adhesion equals bonding. We're talking about composite resins, resin-based materials, and resin adhesives. We're talking about self-adhesive glass ionomers. And we're talking about a variety of cements, both resin-based and glass ionomer, that allow us to adhere to tooth structures to give us better and longer lasting restorations. So think about what we're bonding. From certainly our initial materials, our preventive materials, without any tooth preparation, the use of sealants. We now are placing routinely restorative composites in the anterior and posterior area. And then in 1983, the ability to place very thin ceramic veneers and bond them to tooth substances. We can also place ceramic inlays and onlays, the revolution and evolution of CAD/CAM. We can place fiber posts and reinforce teeth using composites by bonding within the canal and to the post and with the restoration we place. And then our bases and liners are also adhesive to tooth structure. So look at the circumstance where adhesion has changed the way we practice dentistry, from the restoration of a traumatic fracture of a central incisor, or the carious lesion on the proximal surface of an anterior tooth, or perhaps the non-carious cervical lesion, the class 5, or the carious class 5 using adhesive restorative materials. The routine placement to treat caries of composite in the posterior, or the replacement of defective amalgam restorations with composite resin. The use of a fiber post for bonding into place and then using it to reinforce and retain the composite resin to restore a fractured tooth. Or the placement of very thin 0.5 millimeter porcelain veneers bonded to enamel surfaces. The way we practice dentistry certainly has changed, to even the point that we can bond our crowns to place, whether they be ceramic crowns or porcelain fused to metal crowns, that we're bonding them to place. The placement of indirect inlays and onlays using CAD/CAM to tooth structure using adhesive cements, or even the repair of porcelain, where we can etch or sandblast these porcelain surfaces and do a composite resin repair. Our mechanism of adhesion are actually dual mechanisms, both of primarily mechanical locking to a microscopically roughened surface, or that combined with chemical bonding, using of a silane to help us bond to composite to ceramic. And so we have mainly micromechanical retention holding our restorations in place. The forces on every adhesive restoration to both bond and defond those surfaces really come into play, knowing the occlusion and the function, designing your restorations to succeed. Whether it be the microscopic porosities of etched enamel surfaces, or whether it be the porosities and the soaking in of adhesive into a peritubular dentin and dentinal tubules to bond to these substances and these surfaces, that is very predictable. The basics don't change in everything we do in restorative dentistry. We need to control the field and have a level of isolation, whether it be using the rubber dam or extending it to absorbents like cotton or theta triangles. We need to prepare the tooth for a long-lasting restoration to fulfill the needs of the restorative material. We need a clean tooth to have a bonding surface. Our surface treatments must be consistent with what the manufacturer is defining, whether they're telling us to etch or use a self-etch material, and then using a bonding system correctly. And if it's light curing, using the curing light successfully, using it the way it was meant to be used to optimize the energy to those surfaces. And then finally placing our restoration, whether it be composite resin, a sealant, whether it be placing a crown with an adhesive cement. And then light curing when the material desires and needs to have light curing. All these things contribute to success. So it's whether we take minimally invasive preparations into carious pits and fissures. Look how minimal these preparations are in the first premolar and the first molar. And then restoring them with composite resin using an acid etch technique with a light cure adhesive and a light cure composite. Or routine restoration replacement, restoring amalgam restorations, whether it be due to recurrent caries or failure of the restoration, or even the patient desiring the replacement of these restorations for aesthetic reasons, to get a highly aesthetic restoration on the occlusal surface of these posterior teeth. Adhesion works hand in hand with aesthetics, from the minimally invasive composite resin veneer, or the minimally invasive porcelain veneer, or the aesthetics of restoring a traumatically fractured tooth, to more invasive procedures for crowns, where our preparation designs change as we're using ceramics. That there isn't a one-size-fits-all. There are many different adhesives on the market. There are many different aesthetic materials, and you need to work with the one you have the greatest confidence with and success. Whether it be the restoration of these peg-shaped lateral incisors for aesthetic reasons, to place these composite resin restorations to achieve an aesthetic result, and these restorations in fact have lasted over 25 years. Or perhaps the circumstance of placing very thin, minimally invasive porcelain veneers where the porcelain's been etched on the inner surfaces so it can be bonded with a light cure composite resin cement. And so we take an individual who's not happy with the appearance of their teeth aesthetically, where orthodontics can only do so much, and that we need to change the contour of these teeth. And we can do it with porcelain veneers that are planned correctly and bonded adhesively using the techniques that will give us success. Or for a circumstance where you need to do anterior crowns or posterior crowns due to loss of tooth substance or perhaps endodontic treatment. But for these 4 anterior central and lateral incisors, the placement of all ceramic crowns made with lithium disilicate, and that if you look at the interior of these crowns, you can see that these interior surfaces have been etched so that they can be bonded with a light cured adhesive composite resin cement and then placed over those preparations to get a highly aesthetic result that's invisible to the people that see her smile, that's to see this person just speaking. These are her teeth. Or taking adhesion for what we call restorative problem solvers. We can use adhesives to repair traumatic fractures. We can use adhesives to repair and restore the worn dentition. We can use adhesives to place fiber-reinforced composite resin splints. That'll be long-lasting. And so for this case, where a teenager fell and kissed the concrete and fractured the mesial incisal of number 8, and we restored it with a nanohybrid composite and an adhesive technique to enamel and dentin, where this repair is invisible to the eye. Or perhaps when someone kisses the concrete and fractures an existing porcelain fused to metal 3-unit fixed partial denture, that we can repair this ceramic surface with composite the same way we would enamel surfaces, where we can etch the ceramic surface after appropriate preparation with hydrofluoric acid, or we can air abrade this surface with a high velocity aluminum oxide particle, and then restore it using a chemical bonding of silane to that microscopically roughened ceramic with a nanohybrid composite resin that to anyone's eye looks like the porcelain itself. Or what about the fact that we have an epidemic of tooth wear, the worn mandibular incisors? What do we do for these? Well, we can treat these, the worn dentition, this attrition, using adhesive composite resins, doing minimally invasive preparations where we're preparing only into the dentin with a 330 burr or a small round burr or an inverted cone burr to a depth of about 1 millimeter. We're maintaining an enamel shell where we're etching the internal of both the dentin and the enamel to restore these surfaces with composite resin. And these composites are long-lasting. I have some patients where I've done these restorations where we needed no replacement after 12 years. But let's not take bonding for granted. It's not a miracle cure. It takes a knowledge and understanding for both treatment planning, treatment, following the techniques, and in everything we do, good dental practices are key for success. This was Dr. Howard Strassler with the Hints from Howard on adhesives, the evolution of adhesive restorative dentistry. I thank you for your time today.